that it's my distinct pleasure to introduce our own Mady Chalk, who went to high school at the High School of Arts and
Music and Art.
Music and Art in
New York.
Which part of New York? Which borough?
Oh, it was in Upper Manhattan at the time, on the City College campus.
Perfect. And from those humble beginnings,
here I am.
You went through the University of Chicago and Brandeis University and
Columbia.
And Columbia.
Yeah.
Got her Ph.D. in social work.
No, I got my Ph.D. in health economics and health policy.
Sorry.
That's okay.
Anyway.
So great.
I think it's time.
It's time for me to.
It's time for me to stop and for me to start
all right.
talking.
Right. Thanks.
Thanks, May.
Thanks. So, that's just. So my assumption has been that everybody here knows about use of medications and treatment, but maybe not. We'll see. I thought I would start by talking a little bit about what policy has to do with medications and treatment anyway. This is the policy center that I work in with others. And the fact is that without policy analysis and research to know what factors are affecting adoption of innovations, whether it's medication, use of medications in treatment, or whether it's other best practices that all of you are busy creating through your clinical research, the adoption of innovations wouldn't happen. As it is, it's extremely difficult. And there are a lot of resources at TRI that are being used to try to move innovations and best practices into the real world. But the CTN, Clinical Trials Network notwithstanding, the fact is that things do not move easily, and they do not often move with any kind of fidelity. A word about the phrase MAT. I don't like it. I don't know what all of you think about it, or whether you know that it was a simple creation by SAMHSA at one point, the Substance Abuse and Mental Health Services Administration. They had to come up with something to call use of medications in treatment. And they came up with the term medication-assisted treatment. But think about it for a minute and think about the connotation of medication-assisted. Is it medication-assisted treatment for diabetes? Is it medication-assisted treatment for hypertension? No, it's just people who have those chronic illnesses get access to medications if they're appropriate, and like anything else. So slowly but surely, some of us are removing that phrase from our language. I'll give you another example. So all the years we've talked about addiction, or we've talked about substance abuse. The term substance use disorders is a creation. It was some of us said, I being one of those people, about 15 years ago, we need to change the terminology in this field. If substance use is if there are substance use disorders, like anything else, mental health disorders, we've got to stop talking about abuse. It's pejorative, and we didn't like it. So it was Herman Diesenhaus and I, who was somebody I used to work with in the government, who was a very special person, let's just put it that way. said, okay, all the RFAs we write now from the government, we're going to start using the term SUD. We're going to leave out the word addiction, we're going to leave out the word abuse, and let's see what happens. And here we are. There are people who still want to talk about abuse sometimes, but it's certainly much better than it was. The kind of research that goes on related to policy has to do with organizational barriers to innovative practices, and there are lots of them. Cost offsets, return on investment. It is not the kind of research that the Clinical Trials Network does, for instance. They don't do these kinds of research. Nor is it quite health services research, which is quite focused on the services delivered themselves, not what's happening up here at a policy level. But if you were to do some hierarchies, you could start with, the microbiology and the biological and genetic issues. Somewhere along the line, you get to the clinical research, a little further to the services research, and a little further up to the policy research. So, why is the use of medications in treatment, why has it become a very hot issue? And it is a hot issue now. And what I would prefer, by the way, is that I not end up lecturing you guys. I would love it if you would ask questions, interrupt, say, that doesn't make sense to me, or whatever you want to say. You all know about the epidemic of overdose deaths. I don't need to go through all of this. We also know that there are higher death rates in states with high rates of poverty. The non-medical use of opioid pain relievers is costing insurers about $73 billion annually in health care costs. And there was a forum, an all-day forum, a congressional forum yesterday in Washington that was exactly on this subject. And it was sponsored by Senator Rob Portman from Ohio, and Ben Whitehouse from, I can't remember what state he's from. All kinds of,
Actually, Mady, I would be interested, like, in the second bullet point. I would think we might need some new information on this, because when you read that, it kind of gives you the indication of the traditional way we associate heroin addiction with high rates of poverty, inner city, non-white areas. And we know today that that is not true, that it is...
it's everywhere.
It's everywhere.
It's everywhere.
So
right. Right.
But Mark Fishman's,
you're right about that.
Mark Fishman's program in Baltimore, it's in city, but the patients are from the suburbs.
Patients are all from the suburbs, yeah. But the patients that are from, what was interesting yesterday, and I don't know if I have it in a slide, and interesting in general, is that the way it's moved to the suburbs has been through beginning with opioid pain relievers, mostly tried at home from your parents' medicine cabinet. And now that there's been a real effort to manufacture OxyContin, for instance, in such a way that it is not crushable and not, so you can't smoke it. And the fact that they've added product to OxyContin has raised the price and the cost. So OxyContin runs between $30 and $80 a pill. Heroin on the street is $10 a bag in most cities. 5 to 10, depending which city in this country you're looking to buy in. The kids in the suburbs who get addicted and become dependent while on opioid pain relievers and then can't afford them then move to buying heroin on the street because it's so much cheaper. So it's become a significant problem. On the other hand, underuse of medications to treat substance use disorders, particularly opiate dependence, it's very high. We also know, though, that as Medicaid is becoming is more important as a public payer, under parity and under the ACA, and as private insurances are becoming more aware of the effectiveness of medications, there is the possibility of medications becoming better used in the course of treatment. For treatment programs, which some of you work with in your research, that are largely funded by the block grant, there has been a real reluctance to use block grant funds for medications. Not because there's a rule. There is no rule, although programs may say to you, oh, we think there's a rule and we don't think we're allowed to spend block grant funds on medications. That's not true. But they've thought that. Now that programs are shifting to receiving Medicaid reimbursement, it's a different story. On the other hand, the underuse is still going to be, we're going to need to do something about it because non-quantitative treatment limitations, you'll be going to be hearing plenty about that under parity, which in effect is utilization management, utilization review, and that kind of thing, which many of you know about from the rest of healthcare, are heavily in place to make it much more difficult to access medications in treatment of substance use disorders. We also have the problem of state legislatures and governors who, for their own reasons, seem to have thought that they wanted their states to be drug-free, in which they include the use of medications. Some state legislatures, such as Maine, Tennessee, Ohio, and we don't know who's next, are limiting access, if you can believe this, by regulation to medications. So Maine has a statute saying how long.
So when you say medications, do you mean
for
dependence?
Yes.
Agonists, are you talking about
naltrexone, acamprosate, any kind. They're saying, well, you can have this for that length. You can have this for 6 months. You can't have it more than once a year. You can only have one state, I don't know if it's Maine or Ohio, is saying you can only have 8 milligrams of buprenorphine. Great. Have 8 milligrams of buprenorphine, and a pregnant woman discovers that she's gone into labor because it's too low a dose. You know.
Is this cost related or stigma related?
It's discrimination related primarily. That's the other word I'm trying to get rid of, stigma. Because we use it so much. Yeah, no, it's discrimination. Yes, I'd say it was discrimination related. You got it.
When these governors and state legislatures talk about the need to create limitations, what's their basis and what's the rhetoric around it?
It's rhetoric. There isn't. There is there is no basis. They don't talk about anything scientific. They say we don't like it. We simply don't like it. And we don't believe that people who are using any kind of medication, and we don't care what the medication is, are in recovery. They're not. And we don't want that in our state.
Do they do that for psychotropic? Are there limitations on?
No, they don't. Adam.
Some of it too comes from the negative connotations of being on methadone.
Mm-hmm.
You know, like
Yes.
people in methadone programs that are on it for a long time, or maybe for a lifetime.
For lifetime.
That there's this belief that somehow that is
Right.
It's a negative. That's a negative outcome.
Absolutely. And when I almost got a shoe thrown at my head in the West Virginia state legislature, when I went to talk about medications, and I compared medications for substance use disorders to insulin for diabetes, and a guy jumps up and starts yelling and picked up something to throw at me and said, "Don't you dare compare my diabetes to substance use disorders." Jack.
One of the things is why state legislators and governors are opposed to this is sometimes nothing to do with the medication itself. Methadone programs are probably the hot button issue. So some of it's all the Mady's talking about, and George mentioned it, people are opposed to keeping somebody, it's substituting one drug for another. The other thing is with methadone clinics, there's been, over the years, some methadone clinics have been run so poorly, or maybe...
Well, we can talk about that.
People see loitering, they see people hanging out, they see a lot of things happening. So some of the public nuisance issues that you might call it, the images that methadone programs have had.
Yes, that's exactly right.
Et cetera, et cetera. That's an impression. We don't want that in our neighborhood. This isn't helping anybody. It's creating
Right.
bad people. So, you know, there's some issues here.
And,
about
you know,
making sure that we change the way we operate our opioid treatment programs.
Right.
And
Right.
then you've added, then buprenorphine comes along in a time when there's overdoses and all the things Mady's talking about, and there's an increase in buprenorphine on the streets. So this whole diversion is happening here. We don't want this either. So sometimes it's not based on science. It's based
No,
on
it's never
perceptions
based on
and,
science.
Is there any scientific evidence that says a person should only be on one of those medications for 6 months, or that
No.
after, you know, like besides opiates, you know, that after...
No, and George can respond.
Contrary.
There's evidence to the contrary. There's evidence to the contrary, and there are some significant efforts with regard to this whole issue to have individuals who are taking methadone, for instance, and who are and have been for most of their lives, who are mothers and lawyers and doctors and whatevers, come forward and begin to talk about that more openly, so that the understanding begins to change. And that's what this presentation is about.
I know some of you might have heard of us talking about the project we were doing with Public Health England, which is the agency in England that's responsible for managing all the substance use programs. And they had about 10 years ago, they did a huge policy push, national push they had a huge heroin epidemic, and they did a huge push to get doctors able to prescribe methadone, and were very successful. They had a lot of people going on methadone, but they didn't have a lot of programs around it, so it was like just medication without the counseling. And then a new government came in and changed the drug strategy to say it was recovery reorientation. And the rhetoric was similar, that if you're on these medications, you're not truly in recovery, and that the government was preventing people from accessing true recovery. And so Kelly and Kaylee and I did a bunch of interviews with counselors and policymakers in England and asked questions about about, use of medication, and they were saying if somebody is on medication, they are not in recovery. And so I'd say, okay, so what about a person who, has been abstinent from, heroin for 15 years and is a caring parent and contributes to society and has a good job? Nope, doesn't count. They're not in recovery.
Yeah.
So, I think it's just, it's important to say that kind of discrimination at the policy level is really
it's rampant.
international.
It's rampant.
I mean, if you have no medical reason to deny me access to a medication, that's discrimination. It should be illegal.
Yes. Yes, it should be illegal, and it should be illegal. Brenda's right. And there is a beginning groundswell in some places to begin suing programs. Go ahead, George.
I was going to say, this same dynamic occurred in psychiatry, in the psychoanalytic
That's right.
era.
That's true.
Identical. And one of the things that changed it was their Chestnut Lodge, which is the psychoanalytic long-term.
Where I worked.
You worked at Chestnut Lodge.
Yes, for a while.
Yeah, you did, okay. They had a patient who was schizophrenic or depressed. I think he was depressed.
Yeah.
And did not put him on an antidepressant.
And he
The
killed
antidepressant
himself.
Come out, and they had a very bad outcome.
Very
And
bad outcome.
They sued Chestnut Lodge and won. And that single lawsuit, I think,
Right.
changed
Right.
the dynamic.
And so,
It's the same
for
thing.
instance, when I have spoken publicly about use of medications in treatment, whether it's to the West Virginia State Legislature or North Carolina, I've done a lot of talks to legislatures. I've talked a lot about malpractice and suing to begin to get people to start thinking about what's going to happen to them now that there are medications, because there didn't used to be. I mean, let's remember that medications are not this old thing that's been there forever except for methadone. And that has been in a separate treatment system. And you have to remember that. That's a completely isolated treatment system from where naltrexone and buprenorphine and other medications can be administered and monitored, which is in primary care. It makes a huge difference. But programs are going to have to begin to understand that as patients begin to demand, if there's a medication to help me with my craving, I want it. What the implications of that are, not to provide it themselves or not to provide access to it. I don't think every treatment program has to say, okay, we do medications. If they don't have a we'll talk about those issues in a minute. Let me run through these pretty quickly. This is just to give you an idea of what kinds of medications are involved in overdose deaths, opioid sales, deaths, treatment admissions. I mean, look at that. The green line is sales, the blue line is deaths, and look where treatment admissions are. I'm assuming everybody knows what the medications are for alcohol dependence and for opioid dependence. Very important for everyone here especially to know that all the medications are effective. They're not all effective for everyone. Yes, there has to be some assessment done, and physicians have to figure out what medication makes sense for whom. I don't think we've got that issue completely solved. You know, we're not at the point where we can say, well, you would be just perfect for buprenorphine. I think there are a lot of issues involved in who is appropriate for medications administered in a primary care office orally versus who may be more appropriate for injectable, which is Vivitrol, which changes a whole dynamic. I mean, regardless of the medication, medications are effective in reducing opioid use and alcohol use and the risk of infectious diseases and crime. But it is only true if the medications are used as maintenance treatments. So,
I was just going to say, when you give these talks, you should read the policy written by the Russian Ministry of Health.
Yeah. Okay.
And what you're describing in the state legislature could have been written by the Russian Ministry of Health.
Right.
Except they don't allow it at all. I mean,
yeah, right.
6 months. But it might be useful thing. This is, and they'll talk about all the side effects and none of the positive effects.
Right.
And how you're not a real Russian unless you're free.
Unless you're free and clear. Right.
And it's the same.
Yeah.
Just as thought.
But I mean, what? Yeah.
What are we doing?
Well, that's not a bad idea. That's not a. That would be kind of fun.
Yeah, that might be a little.
It would be fun to not tell people where that information was coming from, and then have a conversation about it.
Just be a bit of a gadfly. As far as my understanding, let's not talk about Vivitrol.
Okay.
But either naltrexone, disulfiram, or
Acamprosate.
Acamprosate for alcohol. The literature really sort of indicates that acamprosate doesn't work. That antabuse doesn't work very well if it works at all. And that naltrexone
Not true.
produces very small effect sizes.
Okay.
So if and I think that's an accurate. I mean, I'm very much pro-med, so I'm not.
Yeah, I understand.
So these are small effects if there are any kind of effects at all. So that being the case, I mean, are we making too much of this?
Okay. No. Not in my view. Not in my view. And the reason we're not making too much of this is that the important issue here is access to the medications if they make sense for a particular patient. And we don't even have that. I understand exactly what you're saying, Jim. And the reason that oral naltrexone ostensibly is as quote-unquote ineffective as it is has mostly to do with the fact that patients aren't reliable in taking it, which is how Vivitrol was it's the underlying reason for having developed Vivitrol, and the expectation, in my understanding, is that the next generation of Vivitrol will be even better, will be even longer lasting. A Vivitrol is injectable. It lasts for 30 to 40 days. It completely blocks the opiate and alcohol receptors. And because it's an injectable and it lasts for that length of time, the adherence to not drinking and drugging is better. Well, not, all right. Not.
I would also say that I would agree with what you said for the alcohol medications, but for the opiate medications, I think there's much more
effective, right. And medication, the other important issue is that medication development is very much at the forefront of what research, that level of research is focused on now. Because there are other medications coming. There are medications in the pipeline. Not to put too fine a point on it, it doesn't help when the FDA is busy approving a new OxyContin that is 5 times more powerful and does not have the the attributes that have been built into the old OxyContin, which means you can't crush it, and all of that. It doesn't help. So now we need medications all the more in order to be able to deal with that. But the important point that this slide is trying to make is that if you give a patient medications during detox and you stop them, you're wasting money and you're not doing the patient very much good if you just stop at the end or if they don't get into treatment. I can understand that at the end of detox there are patients who will refuse medications, and for whatever the reason. We don't have any decent studies, by the way, if anybody would care to do one, on patient refusals. We don't know. It occurred to me the other day, what a great PCORI grant. We don't know why it is, what patient attitudes are, whether they're hearing things from their families, whether they're hearing things from staff in a treatment program, whether it's some idea they've developed that they should not or don't want to or have some kind of fantasy about what will happen to them if they take medications.
I don't think a lot of them realize they exist.
They probably don't. They probably don't, Kathy. You're probably right.
For the people that's on medication, are they required to do counseling?
Required to do, yes. Are they required? Yes. Does it always happen? No.
But do they still get medication if they don't?
Yes, there are, but we'll talk about what some of the things are that are not going right in the field, in the treatment field, because we haven't spent enough time paying attention to this issue.
So some patients do great with just medication. Like if you have like a friend of mine has a practice in San Francisco, he treats lawyers and doctors and high functioning who haven't had their lives destroyed. And he puts them on buprenorphine. He says they're doing great. They need very little counseling.
And
the VA, where you got a whole lot of problems, you know,
they don't do all right. And I think it all, for me, having been a clinician myself, that did adolescent treatment a long time ago, but for a lot of years, it never would have crossed my mind that we could develop a treatment plan and start treating patients without doing a full assessment. That's the issue for me. There are patients, as George just talked about, for whom, and there is research, by the way, on this, for whom counseling is not particularly important. It's not going to do much for them.
Well, I saw something on television where this guy had this implant.
Mm-hmm.
And he said, he had the implant, but another guy got the implant. And he said if he didn't come to counseling, it wasn't going to work. So I don't know.
Well, no. I mean, I don't know what that means. I don't know when you say it won't work.
Well, he said it wouldn't work as well because you also needed counseling.
Yes.
To make
I think for many, many, many people, that's true. But I think we need, just as we need to distinguish among patients with different kinds of and levels of diabetes. Yes, they may all take insulin, but they don't all need every kind of counseling. There are some that do and some that don't. This is a study that I participated in with a group of people a couple of years ago. Look at the difference in cost for any patients in a course of treatment for patients who took medications and patients who did not, including the cost of the medication. Now that's any medication versus none. The study also looked at each individual one, and I'm not going to go into that today because that would take too long. But it's pretty impressive.
What period of time is that?
Over 6 months, I believe. No, maybe, no, a year. A year. So there are lots of systemic barriers that have to do with why is it that use of medications in treatment is such a tough slog, and it is. There are federal and state regulations that make it difficult. I think we're all working in the state of Pennsylvania. You might want to know that in this state, at the state level, there are regulations that do not permit residential treatment programs licensed by the state to use medications. Completely dispermitted. What they have to do, Kelly and I have been participating in a study with those folks. They have to use an outpatient pharmacy. They can't do anything inside. They are not permitted to hire physicians. So you have to go to an outpatient physician. I mean, every blockade has been put up to make it difficult.
Will that be legal under parity regulations?
I don't know yet. I think that's to be pressed. Somebody's going to have to start pressing it for us to find out how legal that'll be.
Where does Gary Tennis fall on all this?
Right where you think he falls. He hasn't done anything about that situation, and it is my understanding, but this is just my understanding, Tom has spent more time with him than I have, that he is anti the use of medications in treatment.
Is he really? Historically, that's.
Yeah. Gary Tennis, the drug czar in Pennsylvania.
Oh, God.
Yes. I mean, you know, so there are federal and state regulations that make it difficult, and we'll talk about that in a minute. Their public and private coverage and benefits are not evenly spread across this country, and the division between and siloing of specialty treatment, primary care, and hospitals is problematic, and medical and non-medical staff learning how to work together in our field has been particularly a problem. So at the federal level, you have the whole issue of accreditation and regulation of methadone treatment programs in a separate system of care, completely separate, isolated from the rest of care. There are 2 states currently that are making a run, and I'm going to talk to them very soon, at trying to create medical homes in methadone treatment programs. What Jack said earlier about the quality of care in methadone treatment is true. It's very uneven. It has not, in many cases, stood the test of time. Many methadone treatment programs simply dispense meds. Many of them are for-profit, and you need to know that. You need to think about the implications of that. You go, and I've visited many of them, you go and visit the for-profit methadone programs where it's $7 or $10 a pop to get your methadone and to get your blood tested or your urine tested, and not much else. You can make a lot of money, and there's a lot of greed out there. There are places in this country that are making because so many patients are treated by methadone treatment programs, there are places that are really trying to raise the level of care in methadone treatment so that they can be medical homes, that they have all the medical care that can treat the other chronic conditions that come along with substance use disorders, such as diabetes and hypertension and depression and sleep disorders and a whole bunch of other things. But them being in a completely separate system of care is not likely to change tomorrow, and it's problematic. federal regulation and training of practitioner limitations on buprenorphine is also a problem. Yes, people need to be trained, and I don't have the least doubt about that because of what you can see happening in the field with diversion of buprenorphine and some buprenorphine mills, if you want to call them that. And there are plenty of them around the country. It's, again, for me, I look at it and I say, what is that about? It's about greed, money. But for the first year, after you are waivered, which is after you've gotten your training, physicians can treat 30 patients, and then they can go to 100 patients in the following year if they choose. And they have to continue with getting continuing medical education for buprenorphine. However, go ahead.
But again, it's clearly an example of discrimination.
Yes.
Because there's, I mean,
what other?
There's many other meds that have diversion problems that are dangerous in various ways, but MDs can prescribe virtually any medication.
Right. I mean, if you were to look, yesterday at this congressional forum, somebody was showing slides about overdose deaths, or about deaths, I guess, and showed opiates and mostly opioid pain medications, and then showed benzodiazepines. Benzos are higher than opioid pain relievers, and there's nobody's saying you can only treat 30 patients with benzos. Okay. So the definition of these utilization management, utilization criteria for behavioral health in the ACA and in the Parity Act, it says that utilization review and utilization management and all the things that you have to get in order to be able to get access to medications have to be applied to behavioral disorders and be comparable to and applied no more stringently than. Now you tell me what that means. We're about to find out in this parity study that we're getting involved in working on now. We're going to be taking a look at how are utilization management, utilization review, prior authorization, all of those things applied to mental health and substance use treatment programs compared to healthcare practices, so that we can begin to see what's really going on here. And you know what for those of us who are doing the study, our suspicions are, but we'll see. At the state level, here are the things we don't know that we need to know, and some of us here are going to get involved in finding out more about this. Under Medicaid, now that most of our population, the population of patients with substance use disorders, will be eligible for Medicaid, how are eligible and enrolled providers in networks that treat our patients, are there requirements for them to be eligible and enrolled similar to what they are for a primary care doc? No idea. We're about to find out. What about all the new eligible patients under the ACA that will be criminal offenders, that are criminal offenders? The consent decree in California, Los Angeles County, earlier this year, accepted 47,000 offenders, most of whom were substance use disordered offenders. 90% of them were, according to their county director. we do know that pre-authorization and reauthorization processes currently take weeks and months. We learned that when we were doing an earlier study that Kaylee participated in on medications and talked with people about what was going on.
Katie, I heard something, I gave a talk last week at school, and I don't know that this is Medicaid, but what I heard is that insurance would not cover residential treatment for any adolescent who indicated any hesitation about receiving treatment. And that was a new,
Well, what state is this in?
I'm going to guess Pennsylvania.
Okay, that's possible. It's possible that somebody created that, but that's not a Medicaid requirement. Remember, Medicaid.
But what it says to me, I'm wondering what kinds of barriers are going to be popping up.
There are going to be lots. There will be particularly lots of barriers popping up with regard to residential treatment, but that's another conversation that we ought to have for those of us who, are concerned about that. It is very clear from the Center for Medicaid and Medicare Services that Medicaid reimbursement for residential treatment is going to be very conditional, and it's going to depend on whether whether the states will do it as part of a continuum of care, and whether they will hold the residential treatment programs accountable for assuring that patients get access to the next level of care. And, it's...
That sounds reasonable.
Well, it's...
adolescents have no ambivalence
Right. That's a little silly.
Yeah.
Thinking about the fail first and the step therapy, I don't know if you know this, but what percentage of drugs that have the fail first and step therapy criteria, what percentage are used for or MATs?
Are used for substance use?
So, how, thinking about the world
Of all, I have no idea, Brenda, but that's a good question.
Is it a higher proportion, or maybe it's a
I suspect that both for mental health and substance use disorders, not just for substance use disorders, we're going to find when we look at this, and that's one of the things we're looking at as part of this parity study. I suspect we're going to find that fail first and step therapy is a much higher proportion for the medications that treat mental health and substance use disorders than they are for other disorders. On the other hand, there are some other medications that they're not fail first, but there are some others for which you will hear physicians say, well, we'll start with this one and then we'll move to that if necessary and that. But it's not the purchaser who's deciding that, it's the physician. In this case, we're talking about a Medicaid policy, and we're talking about a purchaser's decision, not the decision of the physician. And that's where that has to be exposed. We need to know whether those kind of policies are affecting what happens to patients in treatment for addictions. There's also this issue of hiring physicians by specialty program. You would be shocked, I think, to know that at least half of the states in this country have regulations at the state level that do not permit specialty substance use treatment programs to hire physicians. Because at base, they still believe that this is a social problem.
Can they hire nurse practitioners?
No.
So no medical staff?
No medical staff. No medical staff. So what they've had to do, so they have two choices. And that's why you hear all this discussion about integrated care. They have two choices. Either hook up with a community health center, a federally qualified health center, or in some states you can contract with a physician practice that will lend you a physician a half a day a week or something like that, or 2 half days a week, to deal both with some kinds of assessments and with medications.
You know what I'm thinking here is, when you just said this, one of the key elements of effective substance abuse treatment is that there should be a medical staff person on site. And so if you are evaluating and giving quality ratings to a program that has legal ramifications that you can't have it,
Yeah.
we've got to deal with that.
Yeah,
And
we do.
everybody fails.
Everybody fails. Right. Right. The coverage, with regard to medications, this is specifically about medications, not about anything else. In most states, 1 or 2 of the approved medications, those are the medications I showed you earlier, are not on a formulary. Not on a formulary. Some of the, as I said, some of the state legislatures are doing this, limits on dosages. Refill limits don't reflect a chronic disease understanding. So they'll say, yeah, you can refill it, but you have to refill it 6 months. And, well, but you only gave me for 3 months, and now I have a break. So what am I supposed to do? It's very problematic. And this business of requiring the programs pre-purchase a medication, but only charge Medicaid following use, means that you have to front money. Now, interestingly, California, and this is very recent, it's within the last 3 months, finally got the message and decided to change that policy. They were one of the states that had that policy. They now have an agreement between Medicaid and about 15 pharmacies around the state, and that permits the pharmacy to dispense, based on prescription, 6 months of like Vivitrol or buprenorphine or whatever in a bulk buy to a physician practice, and you can bill the state. And the state is now paying in a bulk way to get around this pre-purchase issue. But that's new, and we'll see what happens. Then you have this little issue of covering medications only as a medical, not as a pharmacy benefit. You may notice that you really have 3 insurances. In your private insurance, you have your medical benefits, you have your behavioral health benefits, and you have your pharmacy benefit. They are not all in the same benefit package. You may think they are, and it may seem to you that it's seamless, but they're not. And what has happened with this little issue is, if you don't have your medical benefit, just as an example, when we looked at Aetna, when you don't have your medical benefit, your pharmacy benefit, and your behavioral health benefit under the same insurance package, there's a little problem with Aetna authorizing you to have medication. You have to have all your benefits under the single insurer. Well, that's a real problem. It's a real problem. And for treatment programs to be asked to figure that out, or patients even more so, it's next to impossible.
But could this also mean that, for instance, you buy a medication and there's a $10 copay, but you have a medical problem and there's a $1,000 deductible? So does that mean that your medication treatment will not...
It doesn't apply to your medical deductible.
But that's what I'm getting at, that if it's covered as a medical thing instead of a...
Right, and you have to look in your...
Then you might have to use the medication,
right.
$1,000 worth of medication to get any
right.
coverage for.
Right, and you have to look in your own policy to figure that out, because policies differ. In some places, it's covered as a medical benefit. In some places, it's covered as a pharmacy benefit. It's never, the counseling is covered as a behavioral health benefit. So now you try to figure out how to marry up, oh, they got a medication and now the patient's supposed to go to counseling. Well, great. Who is it who has access to how, in a seamless way, to put those two benefits together? Nobody. Nobody. Until we get to the point that everything is integrated care, you can't figure that out, because the behavioral health benefits are, as you know, often carved out. So they hold that privately. The pharmacy folks hold their own databases private, and then you've got the medical folks. So it's not great. The organizational barriers, as you can see, are still very large, because medications are new, they are an innovation, and I'm going to have to stop pretty quick. There are lots of issues, so let me get through this, because I want to get to the last slide. There's lots of issues about lack of training, about use of medications, the impact on patient readiness. We could changes in counseling practices. We could talk about that for a very long time. TERF, whose patient is it? The physician, the counselor. And at base, this is what I think it's really all about. The difficulty that we're having in assuring that patients can get access to medications when they're appropriate, based on a clinical assessment, is an issue of attitudes. And we have to remember that innovations are difficult in any case. In any case, for any disease, innovative practices don't just get adopted easily. There are early adopters. There are people who hang back, and we need to take everything we know about adoption of innovation and best practices and put that to the use of getting medications available to patients in treatment. So with that, I'm going to stop.